Professor Cassidy, and we're going to do just a quick video to review IV fluid types, basics, fluid shifts within the body, and then specifically nursing care related to that kind of critical thinking, and then so how you might care for your patient, but also how you might answer exam questions or NCLEX questions related to this topic. Okay, so first of all, we know we have our intracellular and extracellular fluid. What we're concerned with when we're talking about given IV fluids, it's fluid that's going in the intravascular space, so in your blood space. And then right next to the intravascular space, we have interstitial space, fluid could leak into there. And then, of course, we have most of our fluid is within the cells, intracellular. So first space, and just as I said, is when the fluid is where we want it. When we're talking about perfusion within the intravascular space, that is the first space where we want it to carry all of the nutrients and oxygen we need and to remove the waste. Second spacing is when it leaks out into the interstitial fluid, the space that's right next to the arteries and veins. And that causes swelling. And this could be from somebody who has heart failure, is not able to pump enough, and the fluid builds up from edema. There's other reasons too to have that. If you have an injury, you'll have some swelling. And second spacing can be removed just by elevating the limb, and then it would leak back into the vascular space. And we use diuretics to get rid of that extra fluid, bring it to the kidneys for removal. Now, third spacing is when it's moved into a non-functional space. And this happens when your capillaries open up and large molecules shift out and pull the fluid with it. So this happens in ascites, this happens in ARDS, which is acute respiratory distress syndrome, when in your lungs it shifts into the pleural space. Can also happen in sepsis and burns when there's large fluid shifts, a systemic thing, and they move into a third space. And those need to be removed. Like certainly this with the ascites, that would be paracentesis. So you could take a paracentesis, put the needle in, remove the fluid, and then if it was in your pleural space, they would do a thoracentesis and to remove it when the space is next to the lungs. Okay, so let's talk about that a little bit, just because I want you to have a really strong understanding of solutes and fluids. So the smaller solutes, we have sodium, chloride, potassium, all of those fluid moves through those with osmosis as well. But these larger molecules, specifically here, I'm talking about albumin, that has a stronger pull. It's a bigger molecule, so it pulls fluid more readily. And so that's osmosis, the fluid moving back and forth across a membrane. And when we talk about osmolarity and osmolality, those are really kind of the same thing. They're a amount of solutes in the fluid. So osmolality is just the weight of it, and osmolarity is the space that it takes up, the number in like a liter of volume. But they're really used interchangeably a lot, I've heard, and the normal levels are 275 to 290. Not something you have to memorize because, of course, when you're looking at a lab value, that'll give you the normal ranges in the clinical setting, and on an exam or the NCLEX will also give you the normal ranges. But I want you to hear them both and understand that they really are the same thing. It is just the amount of solutes in the fluid. Now, specifically with albumin, you can see when I'm looking at this beaker on the right, and there's 5%, the fluid that's on the left side, it has 5% albumin, less amount of albumin, and then the other side is 10. When this happens, and this is like when your albumin, you have low albumin, and the fluid shifts into your cavity because it wants to be equal. So if you look over here, the membrane, they're both 7.5% albumin, same percent of solutes to the fluid. That is what happens with osmosis. Okay, so when we're talking about, so that's everything that's happening in your body. So now when we introduce an IV fluid into your body, it also affects fluid shifts. So if I give an isotonic, iso means normal, Ton is the tone, the tonacity of the fluid, how much solutes are in there. So normal, like normal saline is 0.9% sodium chloride. That is the same amount of solutes as your plasma. So it's not going to cause any fluid shifts. It's just going to add fluid to that intravascular space. If I give a hypotonic solution, that has less tone, it has less fluids in it. So it's going to cause fluids to move into cells. And if I give a hypertonic solution that has a higher concentration of solutes in it than plasma. So like if I give albumin, which we saw on the last slide, that is a large amount of solutes in it. So that is hypertonic. And it causes the fluid to move out of the cells and into the spaces around it. So the types of IV fluids, we have crystalloids and we have colloids. The colloids are the one we just talked about, albumin, also fresh frozen plasma. Those are big, large molecules that pull fluid. Over here on the crystalloids, the ones that are isotonic that don't pull fluid are your lactated ringers, your normal saline, which is the 9% sodium chloride, and D5 is dextrose 5% in water. All of those are not going to cause fluid shifts within your body. Anything that has a smaller amount of solutes is hypotonic. So when I look at normal saline, the sodium chloride, if I do 0.45% sodium chloride or 0.33 or 0.25, those are smaller numbers. Those are smaller amount of solutes than the 0.9. So you know those are hypotonic, smaller. And the D5, if I go to a D 2.5%, that is smaller than D5, less solutes, it's hypotonic. Now, hypertonic, if I have the 3% normal, it's not normal, saying 3% sodium chloride, that is, you can see there's more than 3 times the amount of solutes in that. That is hypertonic. That's a lot of solutes and a lot of tone. And with the D5, now D5 in water just has those dextrose, that's the solutes. But when I add D5 in sodium chloride or D5 in lactated ringers, which has a lactate, also chloride sodium, those are more solute. So anytime I put D5 in something else, it does have more solutes in it. So it is hypertonic. And then of course, D10 and D20, those are higher numbers of solutes. So those are also hypertonic. And again, those are the crystalloids, the colloids, which are the bigger, the larger molecules, the albumin and the fresh frozen plasma. Those are hypertonic as well. Okay, so that's the fluid. So what does that mean? Why would I give somebody an isotonic fluid? So somebody who just needs fluid, I don't need to shift their fluid into different spaces. I just need to give them extra fluid because they're dehydrated, they've lost fluid through vomiting or diarrhea, or they've just lost fluid through shock, and I need to give them volume. So that's when I would give them an isotonic fluid. Also, for fluid replacement during surgery, they give isotonic fluids. Now, hypotonic, why would I give that? Now, if I have a high sodium, so I have a high amount of sodium in my plasma, in my blood, and less fluid. So I'm going to give a diluted thing. I'm going to give something with a lot of fluid and less solutes, and that's going to dilute that and also pull sodium off. Also to increase removal into the kidneys scared of extra waste. If I have waste buildup, I would give a hypotonic. So there I might give like a half normal saline. Now for hypertonic, why would I give a hypertonic crystalloid? So I have a very low sodium. And you saw that that's a 3% sodium. That's a lot higher than the 0.9 normal saline. So that's a lot of sodium we're giving that patient. And that is really just to give them a lot of sodium and less fluid. Also, if somebody has cerebral edema, because that sodium that is a solute, and it's going to pull the fluid from the neural tissue back into the vascular space to be removed. So that cerebral edema, we would also give a hypertonic. And then, of course, the colloids, those are bigger, and that's if we have ascites, also if we are bleeding out a lot and we need fresh frozen plasma, or if we have low albumin, some reason why I need to pull more fluid into the vascular space, I would give the colloid. Okay, I found this online. I really liked it because it kind of compares the hypo, which is hypo is low volume, and then emia, low volume in the blood, and the hypervolemia. So starting off with labs, when I'm looking at hypovolemia, so I have low volume of my fluid. So I'm going to have, it's going to be more concentrated, more solutes, low fluid, more solutes. So everything is going to curve up. My specific gravity of my urine and my serum is going to be higher. The hematocrit percent is going to be higher because I have all of my red blood cells, but less fluid. So the percent of red blood cells are higher. Hematocrit is higher. Also, your B1 would be higher. With the hypervolemia, I have more volume, more fluid, and less solutes. It's more diluted. So that means things are going to go down. So my specific gravities are going to go down. My hematocrit percentage go down. My BUN is going to go down. So what nursing considerations and treatment? Okay, sure. So hypovolemia, sorry, you want to give fluid. So if I need to give IV fluid, then we'll give IV fluid, but also it might just be encouraged PO fluid or it might be both. People who have low volume, they're at risk for getting really dizzy, right? When they stand up, they won't be able to, don't have the autonomic response as quickly because they don't have as much fluid. So they could get dizzy, they get orthostatic hypotension. So they're at risk for falls. And then daily weights and INOs, those are both hypovolemia. Now for hypervolemia, I'm going to give a low sodium diet because I don't want them to have bring more salt in their body because they already are retaining fluid. We might give diuretics to get rid of some of those fluids. And then also the thing to consider is when you have too much fluids, you're at risk for edema-dependent edema, but also when you lay the person down, that volume could, seep into their lungs and make it harder to breathe. So you probably wouldn't be laying these people flat. Okay, so we're looking at causes. Why would you have low volume in your blood? It could be from if you went to dialysis and they took off a little bit more than used to, a thoracentesis or a paracentesis and fluid shifted out back into those spaces. If you're bleeding out, if you have an NG tube that's removing fluids from your gastric site, also not vomit and diarrhea a lot, that's getting rid of a lot of fluid. So all of these things are going to cause hypovolemia. Also, a third space in which we talked about related to sepsis or another type of shock, burns, ascites. And if you're urinating a lot from diuretics, if you're over diuresed or diabetes. And then with hypervolemia, that could be related to kidney failure, heart failure, liver failure, too much sodium intake. I know we take a lot after Easter when people like those really eat the salty hams. You have a lot of people come in with hypervolemia after that. And then what are the signs and symptoms? So low volume, of course, you're going to be lower blood pressure. You could have weak, thready pulses. You could have lower blood pressure, decreased weight. If it's over a couple of days or even longer, you could have like decreased skin turgor, drier skin, dry mucous membranes, and you should feel thirsty as well. Increased volume, you're going to have that edema, you're going to have weight gain. Blood pressure is going to could be elevated. Your heart rate could be increased. Your pulses, peripheral pulses could be bounding. Those kinds of things. All right, so let's put it all together because when you have a patient on the floor and when you're, I should have separated, I meant to separate these out a little bit, but this is just a list. So we'll go through it. With every patient, whatever the fluid status is, you're going to want to trend your blood pressure because if you have a lot of fluid, you're increased for a lot higher blood pressure. And if you don't have as much, you're at risk for a lower blood pressure. Your heart rate, which could be responsive to that, and your respirations also. You're going to monitor your eyes and nose and daily weights, check your labs, your renal function, make sure you're checking their urine. That's for all, hyper and hypo. Now, for hypo specifically, we talked about this, you're going to have weaker, thready pulses, right? You want to do more frequent repositioning with these. Their skin's at higher risk for breakdown. Also with hyper too, and we might give them IV fluids or encourage PO fluids. Educate the patient. That's always the case. And then this is the hypervolemia. Now here you might hear extra heart sounds, right? You hear an S3 or an S4, depending on, what the volume is related to. You might hear crackles in their lungs. And these are all, this is all just review of stuff. So I'm sure you want to, I just read these over and make sure that you have a good understanding of these. But the trick here is also connecting what's going on. So you have your patient, you have the knowledge, but you have to connect it to what your patient needs. And when you have a test question or you have an NCLEX question, you have to be able to connect it. So if a patient comes in and they've been vomiting and having diarrhea for 3 days and haven't been able to put anything down, you are already thinking hypovolemia and you're already thinking all of those things associated with it. They might have a low blood pressure. I expect that they might be dizzy. I expect that they might get orthostatic when they stand up. So I need to, keep them, um, make sure that they're a fall risk if that's appropriate. So when the question is saying what intervention would you do, this is the critical thinking part of it. You have to connect the fact that your patient who has had diarrhea and vomiting for 3 days has probably hypovolemic, and you have to make sure that if they're whatever the question is asking, it's not going to specifically say, what is this, blah blah, but it might say monitoring nose. Okay, that goes with that, or put them on a fall risk. So you need to connect that those go together. That is the critical thinking piece of it. Oh, and that is it. These are my references for my images, and this is my contact information. Definitely shoot me an email if you have any questions, or grab me after class, okay? I hope this was helpful.